Hi class, let's start up our discussion on the respiratory system. Our respiratory system is the system that's primarily concerned with putting air, or oxygen more specifically, into our bloodstream and then removing that carbon dioxide from our bloodstream. There are some other features like acid-base balance as well that we're going to talk about. Now first we need to focus on the anatomy of our respiratory system. There are two broad regions of our respiratory system. We have the upper respiratory tract and then we have the lower respiratory tract. The primary structures of our upper respiratory tract include our nasal cavity, our pharynx, and then the larynx. And if we look at our lower respiratory tract, those structures are going to include the trachea, and then after the trachea we'll have the bronchi, and then after the bronchi we'll have bronchioles, and after the bronchioles we'll have the alveoli. And these bronchi, bronchioles, and alveoli are all going to be contained within some large sacs known as the lungs. And to help our lungs, we have two of them, one on the left, one on the right, to inflate and deflate, we have a large sheet of muscle known as the diaphragm. Now if we look at the pathway that air follows as it's moving through our respiratory tract, in an ideal situation the air will start at our nose, or enter our body through our nose. It is safer for us to breathe through our nose. So for those of you who are open mouth breathers, I feel your pain, sometimes you have a stuffy nose, but it's best to breathe through your nose. And that air will go from the nose to the pharynx. You can think of the pharynx as the back of the throat. The pharynx is a passageway that has both food and air going through it. After the pharynx, the air is going to be diverted into the larynx. You can think of the larynx as the voice box. And then, as I mentioned before, that pharynx you can think of as the back of the throat. I'm pretty sure I spelled throat incorrectly there, but oh well. After the larynx, we're going to go to the trachea. This is commonly referred to as the windpipe. After our trachea, we're going to go to the lungs. Our lungs are going to contain bronchi, bronchioles, and alveoli. So, class, which of the following is the smallest structure in the pathway of airflow? We have the mouth, the larynx, the alveoli, the trachea, and the bronchus. So go ahead and rewind the video, or you can pause it and check your notes, or check your textbook and get me an answer. 5, 4, 3, 2, 1. Alrighty, the correct answer is the alveoli. The alveoli are the smallest structures within our pathway of airflow. They were also the last structure listed on this slide. And if we go back, they are the small little circle I drew at the end of the pathway of airflow, represented by that circle right there. So moving on, let's talk about the upper respiratory tract, our nose, pharynx, and larynx. If we look at the nose, we're going to have a nair. A nair is a technical term for nostril. Almost everybody's just going to refer to that as nostril. But technically we have an external nair and an internal nair, or an external nostril and an internal nostril. So know that that term nair means nostril, but also be able to switch back and forth and use the term nostril when talking to a patient, because the term nair is just going to be confusing to them. Within the nasal cavity, you'll find that there are folds of tissue in this large nasal cavity, and this large nasal cavity is going to lead to the next area, the pharynx. And this pharynx can be broken up into three regions. There's an area just next to the nasal cavity called the nasopharynx. And that nasopharynx, generally speaking, is going to start right here, and most textbooks will say ends at the tip of the uvula. And the uvula is that small structure that dangles in the back of your throat. There we go. So right there is the uvula. So our nasopharynx goes from the end of the nasal cavity to the tip of the uvula. And then we have the oropharynx. Our oropharynx corresponds to the oral cavity, and it starts at the tip of the uvula, and typically will go to the tip of the upright epiglottis. So here's our oropharynx. When somebody opens their mouth and says, ah, and sticks out their tongue, you are looking at their oropharynx. And then finally we have the laryngopharynx. This laryngopharynx starts from the tip of the upright epiglottis and then goes down to the beginning of the esophagus. And these three regions combined, the nasal pharynx, oral pharynx, and laryngeal pharynx, all make up the pharynx. And that's where we have both food and air potentially go. Afterwards, we're going to have the larynx. And that larynx is going to start right here. So we can think of our larynx, and this is kind of a variable region because as the epiglottis goes down and back up again, the size of the larynx can change, but our larynx typically is going to be considered this region right here. And then right after this large piece of cartilage right there called cricoid cartilage, we're going to enter into the trachea where we have much more regular repeating subunits of hyaline cartilage. So our upper respiratory tract starts at the nose, goes to the pharynx, and then ends with the larynx. After the larynx, we are going to have the lower respiratory tract. Now, if we look at our nose, those nares on the outside of the nose are going to lead into the nasal cavity, or the sometimes also referred to as the nasal sinuses. And within our nose, within that nasal cavity, we have lots of hairs, particularly by the external nares. Those hairs are going to filter out very large particulates. Think of bugs, bits of leaves, big things that we don't want to get into our nose. And then we're also going to have lots of mucus in our nose. The mucus serves two purposes. It is going to filter fine dust particles out of the air, but it also conditions the air. It adds humidity to the air as well to help prep that air for going down into the lower respiratory tract. To help with warming the air, we're going to have lots of capillaries within our nasal cavity. Those capillaries are going to deliver blood to the nasal cavity, and that blood will carry heat. And these capillaries are very close to the surface so they can transfer their heat from the blood to the incoming air. This is one of the primary reasons why it's so easy to get a bloody nose, especially if you're one of those people that like to pick their nose a lot, and you can instigate bloody noses quite easily. The capillaries themselves are also going to have fluid leak out of them. That fluid will go to the mucus, and then the mucus moistens the air or conditions the air. We also are going to have some specialized odor receptors within our nasal cavity. Those odor receptors are going to be on the superior margin of the nasal cavity, which is a nice way of saying that the odor receptors are right on the top of the nasal cavity. And then there's small nerve entries that go directly to the olfactory bulb of the brain. We also are going to have some tear glands that drain into the nasal cavity. Technically, those are referred to as the lacrimal ducts. And those tubes are going to go through the lacrimal bone and drain directly into the nasal cavity. This is one of the big reasons why if somebody's feelings have been hurt, or they've been crying, if they just had something that's caused them to tear up a lot, many times that leads to a runny nose because those excess tears drain directly into our nasal cavity. Let's see if we can find the opening. It's about right there in the lacrimal duct, and it is not shown on this figure, so I won't point it out for you. But needless to say, there is a tube that goes from the eye to the nasal cavity. After our nasal cavity, we have the pharynx. Our pharynx is going to continue to moisten and filter the air. We still have mucous membranes in our pharynx, and we still are going to have lots of blood capillaries close to the surface. Our pharynx is commonly referred to as the throat by most individuals. And we've already talked about those three portions: the nasal pharynx, the oral pharynx, and laryngeal pharynx. The top portion by the nasal cavity, the portion directly behind the mouth, and then the portion directly above the larynx, the laryngeal pharynx. Within the pharynx, we are going to have some specialized structures known as tonsils. And these tonsils aid our lymphatic system. These are secondary lymphoid tissues. We can still have a functional lymphatic system and immune system if we have tonsils removed, but it just won't function as well. As we are constantly bringing particulates and pathogens into our body through our mouth, through our nose, we are going to sample those potential pathogens with our tonsils and prep our immune system to get ready for them. After the pharynx, we have the larynx. And the larynx, commonly known as the voice box, is going to be a structure encapsulated by cartilage. One of the large pieces of cartilage on the larynx, called the laryngeal cartilage has a bulge on it that gives us a structure known as the Adam's apple. In colloquial terms, technically it's referred to as laryngeal prominence. Let's back up a couple slides here. Oh, too far. So, looks like I need to erase some stuff here. That laryngeal prominence is right there. That is also known as the Adam's apple and is a cause, or is part of the laryngeal cartilage. And I can already see a mistake in this figure because this laryngeal prominence is supposed to line up with that bulge right there in the soft tissue of the neck. Whoops. In the larynx, or I should say the larynx is protected from the pharynx by a fold of flexible tissue that is called the epiglottis. And that epiglottis will fold down to protect the larynx from food that's traveling through the pharynx. It's unfortunate these terms sound so similar. So if we look back at our original figure here, we can see this big fold, this epiglottis. Epi meaning above. What is it above? It is above the glottis. And you can see the glottis is beneath the epiglottis. I digress. When somebody swallows something, the epiglottis reflexively will fold down over the opening to the larynx to keep that food and or beverage from going down our larynx and instead funnel it down the esophagus, which is posterior to the larynx. And that epiglottis is going to cover up the opening or the hole in the larynx known as the glottis. So that glottis really is just the opening that all the air goes through as it's going through the larynx to our lungs. And to make up the lateral margins of the glottis, or the left and right sides of the glottis, we are going to have some cords or some strings of connective tissue known as vocal cords. So when you are changing the pitch of your voice from high pitch to low pitch, you are actually going to change the tension on your vocal cords and change the size of the opening that makes up the glottis. Here is an actual photograph of someone's larynx, and here's an idealized figure. So in the actual photograph, you can see the epiglottis sticking out right here. Ooh, I should switch colors. Let's go to green. So here we go. You see the epiglottis right there, and that epiglottis can fold down and over to cover up this opening. This opening is the glottis. And then on the margins of the opening, colored in blue, we have vocal cords which serve to give us our voice. So, class, concept check. What is the relationship of the glottis to the epiglottis? Is the glottis an opening that is inferior to the epiglottis? Is the glottis a fold of tissue that is inferior? Is the glottis an opening that is superior? Or is the glottis a fold of tissue that is superior? So go ahead and rewind the video to get me an answer. Check your text, check your notes, pause it, and get me an answer right now. 5, 4, 3, 2, 1. The correct answer is A. The glottis is an opening which is inferior, which is a nice way of saying closer to the ground, compared to the epiglottis, which is a flap of tissue that folds over the glottis. Let's look at our lower respiratory tract. Our lower respiratory tract is going to consist of the trachea, also known as the windpipe. After the trachea, we have the bronchial tree, which is a nice way of saying that we have lots of branching tubes inside of our lungs. And if we combine these branching tubes with the trachea, it looks like we have an upside down tree, where the trunk is right here, and then we have lots of branches within the lungs, hence the term bronchial tree. And then finally we have the lungs as a whole, the two large sacs where we have most of our external respiration or air exchange between, or gas exchange between the air and our bloodstream. Let's first talk about the trachea itself. The trachea, or the windpipe, as it's often called, is going to connect the larynx with the primary bronchi. These primary bronchi are the first branch points. So we are going to have the trachea, and then the trachea branches to the left and right lungs. And then these first two branches to the left and right lungs are referred to as primary bronchi because of their very first branches. There is lots of connective tissue within our trachea. So this connective tissue is going to serve to anchor it in place. We'll also have smooth muscle that can control the width of the trachea. And we have hyaline cartilage rings that help to prop the trachea open, to help keep our windpipe from collapsing. Our trachea is also going to have lots of cilia. And if we remember back to earlier chapters in our course, cilia are small extensions from the cell that move a substance past the surface of the cell. What are these cilia specifically moving past their surface? They are going to move mucus past the surface of the cell. And these cilia will move the mucus up and out of the trachea. So we'll have cilia constantly moving mucus up and out of the lungs. And that's referred to as a mucociliary escalator. This mucus moves up, out of the lungs, and then oftentimes is going to be swallowed and sent down the esophagus. And as that mucus is being moved by the cilia, it's going to serve to help keep the lungs clean. The mucus will collect more dust and particles, pollen, mold spores, etc., and then will be carried out of the lungs to help clean our lungs. So here's a diagram showing the mucociliary escalator. That's kind of a fun term to say. You can say that with me again, mucociliary escalator. You can impress somebody at a cocktail party now. Well, maybe not. Anyways, if we look at this mucociliary escalator, you'll find that there are goblet cells secreting mucus. And these goblet cells are constantly secreting mucus onto the surface, and then particles get stuck in that mucus, and then the mucus is constantly being moved upwards, up and out of the trachea, carrying the dust with it. Now, if we look at our bronchial tree, as I mentioned several slides ago, the bronchial tree has the trachea as a trunk, and then the bronchi and the bronchioles as the branches. We'll start with those two main bronchi that are going to be the first two big branches. So we could have a trachea right here as our trunk. Then we'll have two big bronchi, primary bronchi as the first two branches, and then they'll keep branching over and over and over again. There's up to 23 orders of branching for these bronchi and bronchioles. So we can have secondary branching, tertiary branching, quaternary branching, so on and so forth and we can repeat that process 23 times over, and it looks like an upside down tree, aka the bronchial tree. These bronchioles are going to go to smaller and smaller and smaller tubes until they eventually end at elongated sacs known as alveoli. And these elongated sacs that end at alveoli are where we have our gas exchange between the air and the bloodstream within the lungs. If we look at the lungs themselves, these large sacs that contain most of the bronchial tree, the lungs will contain the secondary bronchi, the bronchioles, and all of the alveoli that make up the volume of the lungs. And it's worth emphasizing that the right lung has 3 lobes, while the left lung has 2 lobes. Each lobe of the lung is going to have a secondary bronchi going to it. So because the right lung has 3 lobes, the right lung will also have 3 secondary bronchi. We'll spell it out there, 3, whereas the 2 lobes of the left lung correspond to 2 secondary bronchi. Within each lobe, we'll have lobules that have a tertiary bronchi going to them, and then anything past the tertiary level, we just collectively refer to as bronchioles. So anything at the branching order between branching order number 4 and number 23 is collectively referred to as a bronchiole, just because it gets to be a pain in the butt and the tubes get to be too small to distinguish from each other. Now, surrounding the lungs, we have a special serous membrane known as the pleura, or sometimes referred to as the pleural membrane. This pleural membrane, or the pleura, has 2 layers to it, like any good serous membrane. There's the inner and outer layer. Think back to earlier in the course when we talked about membranes. The inner layer, that inner membrane around the lungs, So let's say here's our lung. The inner membrane around the lung is always going to be the visceral one. The serous membrane against the organ is the visceral one. And then it's going to be continuous with the outer membrane, which is the parietal membrane. So in red we have the lungs, in green I have the visceral pleura, and in blue I have the parietal pleura, and both the visceral and parietal pleura combine to form the pleural membrane that surrounds the lungs. Now if we look at the alveoli within the lungs, they're very tiny, and there's approximately 300 million alveoli within our lungs, or about 1/3 of 1 billion alveoli within our lungs, assuming we have healthy, properly functioning lungs. These alveoli have very thin membranes around them. This is called the respiratory membrane, and it's made of a simple squamous epithelium. So it's going to be made of one layer of very thin cells. And we want that one layer of very thin cells to make up our alveoli because we want to maximize the rate of gas exchange across our alveoli. We'll have lots of blood capillaries encircling those alveoli so that we can have the exchange between blood gases and the gases within the air that fill up the alveoli. Alveoli are also going to have a special chemical that line them. This chemical is known as a surfactant. Generally speaking, you can think of a surfactant as biologic soap, or just soap in general. It's a molecule that has a hydrophobic region and a hydrophilic region. And surfactant will form a film around the alveoli that reduces the amount of surface tension that will close the alveoli. In other words, this surfactant helps our alveoli to stay inflated or stay open. Surfactant is one of the last things that we start to produce in our lungs before we are born. And a common problem for prematurely born infants is that they do not have enough surfactant in their lungs, and they'll end up with a condition known as respiratory distress syndrome because they have a hard time opening their alveoli. Here we can see that terminal bronchiole going to an alveolar tube, which then goes to lobules, which are made of individual alveoli, and each individual alveoli is going to be surrounded by blood capillaries, where we have oxygen enter the bloodstream and carbon dioxide leave the bloodstream. So, class concept check. If somebody smokes a lot and loses their respiratory cilia, what will likely happen? Will they have particles accumulating in their lungs? Will they have mucus accumulating in their lungs? Will they have increased bacterial growth in their lungs, or all of the above? This is kind of a stinker question. You have to think about it kind of hard. Go ahead and rewind the video, and I want you to project and think about what we've talked about earlier in this course with both prokaryotic and eukaryotic cell growth, and get me an answer. 5, 4, 3, 2, 1. The correct answer is all of the above. If the cilia break down, first, mucus will start to accumulate in the lungs because the cilia moves the mucus out of the lungs with the mucociliary escalator. Built into that mucus, stuck in the mucus, there are lots of particles. And many of those particles are going to be bacterial endospores. And if you put lots of warm liquid with gooey liquid with nutrients in it and bacterial endospores in that warm, gooey liquid, we're going to have increased bacterial growth within our lungs that can lead to some respiratory issues in the patients. So the correct answer is all of the above. Oh, now we're going to stop right there. If you have any questions about this material, please feel free to shoot me an email, post them on the class discussion board, or swing by my office when you're on campus. Happy studies!